Hi everyone, thanks so much for joining us. Tonight we're going to spend a little bit of time talking about HipAlign or OrthAlign technology for hip replacements for patients positioned in the lateral position, what we're calling a solution for hips from straightforward to complex. I want to thank anybody who's taking the time to listen to this and thank ViewMedi for allowing us to put this out there for people's education. And also obviously a big thank you to OrthAlign for setting this up. I've got disclosures, the most important of which is that I am a designer for this technology and do receive royalties for its use. So I want to thank our faculty for coming out tonight. I know everybody's got a busy schedule, so I want to really thank them. Dr. Don Hohman from Plano, Texas. Don did his residency at University of Buffalo and then a joint replacement fellowship at Brigham and Women's. He's joining us tonight and is going to share some really interesting cases, both from the straightforward case to show the importance and the use of this technology, and then out to the more complex cases where you can see that even without all of the normal anatomic landmarks, this technology really allows for hip replacements to be done smoothly and predictably. Next, we have my colleague, mentor, and friend, Dave Mayman. Dave is the director of our computer-assisted surgery group at Hospital for Special Surgery in New York City. He trained with us many years ago after sneaking across the border in from Canada. Tonight, we'll kind of go through a basic introduction of the technology. I'll talk a little bit about sort of how it works and the basic setup, and then, like I said, Don's going to take us off in some case presentations, and then we're going to finish up with Dave talking about incorporating the concept of the spine and how to deal with complex spine deformities in the setting of hip replacements using navigation, and then we'll have a few extra minutes for Q&A. We'll try to not keep this too long. I know some people try to watch these in between cases, and so we'll try to keep it under half an hour, although if you work at some of the hospitals that I've worked at in my career, you could have a 3.5 or 4 hour presentation and still have time for lunch between cases. So if you don't know much about the OrthAlign technology, it's a fairly simple and straightforward system. It's a handheld smart tool based on accelerometers and gyroscopes, and it exists not only for hip replacements, but for partial knee replacements and for total knee replacements. Now, we released the hip replacement version of this over the last couple of years, both for patients in a supine position, for instance, for a direct anterior approach, or for patients positioned in a lateral position for a posterior approach or a direct lateral approach, or even an anterior-based muscle-sparing approach in the lateral position. It's got some advantages in that there's no capital expense for this technology. It's a per-case basis use, and that can make it very reasonable for lots of surgeons to integrate into their practice. And it is open platform, so probably like you'll see in some of the cases today, this can really be used with any hip replacement implant system that you're comfortable with. So the first question, of course, is why would you even bother coming to this webinar? Why do I navigate hips? Well, I navigate hips because there's only certain quantifiable aspects of hip arthroplasty. The most commonly discussed are cup placement and leg length and offset. Now, we care about cup placement for several different reasons. We used to talk a lot about the safe zone as defined by Lewinnick a very long time ago, in fact, before I was born. And he talked about this inclination and anteversion position whereby if you put it there, cups would be safe and the hip wouldn't dislocate. I will tell you that much of the information we know now shows that this probably isn't all that important as an absolute number, but your target still matters. Now, why aren't we that good at finding that position? And it really comes from a lot of the variation and variability in hip replacement positioning, meaning the patient moves throughout the case. The pelvis moves because of retractors, because you're pulling and dislocating the hip, because you're placing forces on the pelvis while reaming, and sometimes it's simply insufficient pelvic support or a lot of soft tissue in the high BMI patients. So from the beginning, as soon as you begin your surgery and manipulate the patient, the position of the pelvis can move, which can make it difficult to position your cup accurately. And we've seen with this paper, which was published by Jonathan Danoff, who was at Columbia at the time, that only 63% of his cases that he reviewed fell into that safe zone. Now, the point of his paper wasn't just that the safe zone was important, but simply that that was their target, and they had difficulty achieving that target predictably in every case. Leg length is another thing that's not always that easy to understand. There's variabilities in depth and direction of reaming. There's variabilities in the seating of our stems. There's errors built into our templating process, especially if you don't have calibrated x-rays. There's implant design that simply makes it more challenging. And there's changes in the relationship between the femur and the pelvis, especially as you pull on the leg, right? Distracting the leg will abduct the leg and or rotate the pelvis, which can dramatically change the apparent leg length that can also be sensitive to rotation and flexion. And because of all these, we need a more reliable and measurable way to do both leg length and cup position. Leg length is sometimes quoted as the most common reason for lawsuits, although recent publications actually state that that's an infection. And patients may not perceive leg lengths that are minimal, but if you lengthen somebody, you're certainly going to be worried about it. And more importantly, if there's a way not to lengthen patients and a way to be more accurate in leg length recreation, I think we all would agree that that's an important goal. So the question doesn't talk that much about why do I navigate, but I think we'll talk about how do I navigate. And I navigate as a posterior approach surgeon with the lateral position HipAlign system. And it starts with basic patient positioning that looks like this. Patient is positioned in a standard lateral position. We've got both anterior and posterior support on the pelvis. The operative leg is draped free with the leg cover, in this case either a Coban or a stockinette, drop down a little bit, so not coming up to the mid-thigh, but just a little bit above the knee. And of course, the important thing to remember is to get that top drape up above the pelvic rim so you can place your pins in the pelvis. You can see that there's a magnetic plate placed on the lateral side of the femur, and that allows for your targeting device for use later when making sure you're getting your leg length correct. 2 pins are placed in the crest of the acetabulum, and personally, although I'm going to ask some of our other faculty later, I like to put these straight up and down in the pelvis, so not down the pelvic rim like you would for an external fixator, but straight up and down perpendicular to the floor, because I think it makes it a little easier to register your leg length. And these are pretty solid pins that sit well within that thicker brim cortical bone. Then you place the jig and move on to the next step of the surgery. The next step is registration of the table, meaning registration of where is the patient in space as soon as the case starts. And you'll notice in this picture, if you can see kind of underneath our arm here, the incision is not made yet. So this is being done prior to anything with the surgical exposure to minimize any change in position of the patient. The patient is in their absolute ideal position when you start, and that's when you want to register their position. This way, as they move or rotate throughout the case, that doesn't affect the location or the positioning that the system thinks you're in. Leg length is registered by placing a tack in the femur and simply placing this calibrated reader on. The system is going to allow you to register that and then check the change in that leg length later on in the case. Finally, when it's time to position your cup, you'll see that with a sensor attached to the acetabular impactor, you can watch a live reading of the abduction position and anteversion position of your socket while you're placing your cup. Generally, I like to do this both just before impaction, and then I like to check it again after impaction, kind of a double check to make sure that I didn't move or change as I was impacting the cup. But all of these things you can read in the technique guide. So I think what we all really came here for was to hear how this works. So why don't we go on and go ahead and see some cases, and I'm going to ask Don to take over.
Thank you very much. I'm Don Hohman. I work in Texas. I work in Dallas, and also do some surgery in Plano. And I have just some cases that I found this technology to be really quite helpful with, and I thought they would be nice to share, and hopefully they'll stimulate some discussion. What I tried to put together here was just some of the recent things that I've done in the last maybe 3 to 6 months. And really, you know, it's nothing too extreme, but hopefully these will highlight some of the benefits of this technology, and they sort of follow a little bit of a continuum. So they're going to go from a little bit more of a routine to a little bit more of a not so straightforward kind of operation. So much like we've seen already previously demonstrated with a wonderful explanation leading up to this, this is going to be an application of the HipAlign system, and these are cases that were done through the lateral positioning and also with a posterior approach. This is just some pictures of some cases which we were completing recently just for illustrative purposes. So this is a case of a patient. This lady is around 78 years old. You can see she's no stranger to orthopedic procedures. She's got sort of a malunited hip on the right side, but the left side is the one that's really given her the trouble. And what I found with these kind of cases is that this is sort of these patients that have this almost erosive kind of deformity. When you expose this hip, there's a lot of heterotopic bone. There's difficulty with identifying some of the landmarks that you might use to position the socket in your routine setting. And so when you have one of these almost, sort of a oval type acetabulum, it's a little bit more difficult to know exactly where you're putting that cup and to, put it exactly where you might want it. And so this has been the kind of case where I found this kind of technology to be really quite helpful in helping me to provide very reproducible, very consistent results for my patients. And so this has been a nice, streamlined process for me to get to that point with these kind of surgeries. Another kind of case, a little bit more of a challenging operation, a little bit of a larger man, and this is a younger guy who has sort of a, whether this was a post-traumatic issue or if this was AVN, which led to him having, again, a similar sort of situation, a lot of extra bone that's going to be present around the acetabulum. It's going to require a lot of further dissection. Again, when you dislocate this hip and you're looking inside there and trying to identify something that's going to provide you with some keys as to where you might be in space. Again, with a larger patient, this can be challenging, and this is again where I found this technology to be really quite helpful. I think that the benefits in the larger patients, especially in the posterior exposure, can't be overstated. What I've always found is that these require a fairly large incision to get your hand into the appropriate position to get the socket where you're going to want it to be, and more information is always better than less. And I found that with this kind of technology, this has really helped streamline that process and maybe make those incisions smaller, or really help take some of the guesswork out of that, especially in the larger patients. So in these large muscular men, or if you have a heavy patient who has required a lot of soft tissue dissection, this kind of thing can help streamline that process, get you a more reproducible, accurate result in a much more expedient. These are some cases where I really started thinking about the application of this kind of thing, and I tend to see some of these almost, I'd refer to these as my young hip patients, or somebody who's had herpes, which has led on to a degenerative hip at a very young age. And I think that with these patients, these are people that really give me a little bit of heartburn when I think about taking care of these patients, because I think that these are the people that, we owe it to them to really provide them with the absolute optimal position. These people tend to be very young when they present with these deformed hips, and these are challenging hip operations when everybody here is taking care of one of these cases, I'm sure, but when you dislocate this hip and you look inside that acetabulum, it's not shaped like an acetabulum. It's like a big flat plate. And so, where do you start? Where are you going to try to end up? How are you going to get the position that you need? And so this kind of technology, I think, has really been helpful for me to reproducibly position these implants in these patients. And I think these are the kind of people that we really owe that to, because they are going to be, they're going to have these hips for many, many years, and so for us to provide them with the most reproducible and optimal result that we can, I think that is paramount. And again, this is just another example of one of those kind of hips where there was, really no identifiable landmarks that are inside that socket. The other thing with these patients that I've always found to be a little bit challenging is that they have these severe shortening deformities, which makes restoration of leg length a little bit challenging. So the additional information that you get from leg length, in real time is also really very helpful. You would never want to lengthen one of these too far, or the ability to know exactly where you were, may change your decision at the time of surgery. Maybe you need an osteotomy or something, you may need to change your course based on where your implants wind up. And so it's also very useful information. More information is always better than less in these complicated kind of operations, especially in these young patients. This was a young woman that I took care of. To complicate matters, that implant was inside the femur, and she was also quite large, as you can see by some of the soft tissue which hangs over the front of the x-ray there. So this was a real challenge. She had some deficient bone posteriorly, which is hard to appreciate on this x-ray, but the technology was very helpful to position this implant in an optimal position. Not to mention that that took a little bit of the stress out of it with getting that screw and those implants out of there was a little bit of a hassle. But nevertheless, she's gone on to have an excellent, very functional, successful result. In this kind of case, I've also found these to be also quite challenging. You know, these kind of cases with these deformities and essentially a fused hip here with sort of a puzzle piece kind of articulation. These require a lot of extensive dissection in order to safely dislocate this hip, but then trying to recreate the acetabular side of this hip is also a challenge. Where do you start? How far do you go? Again, there's no landmarks. You know, it takes a lot of removal of bone just to get into the hip in this kind of setting. So when you don't have your normal anatomy to reference and some of the things that you might be expecting to base your positioning on, additional technology and additional information is always very helpful. And additionally, leg length information in a case like this is never a bad thing. So that's also been really quite helpful with that kind of case. So those are just a few of the ones that I had in the last 6 to 9 months, and I appreciate the opportunity to share them with you, and I look forward to any questions and looking forward to the further presentations. Thank you very much.
All right, thanks very much, guys. So I'm just going to take this one step further and talk about one of the research interests that we've had at HSS over the last few years, looking at how the spine and the pelvis really affect what we do with hip replacement, and starting to talk more about functional position of acetabular components, a little bit more than anatomic position of acetabular components. And just to reiterate what Dr. Ass spoke about a couple of minutes ago, the development of OrthAlign for the hip, there were really a couple of guiding principles, and I try to remember these as I'm going through this. But the guiding principles were no large capital equipment cost, as Mike spoke about, so this can be used on just a case-by-case basis, but then thinking about what surgeons actually want when they're navigating hip replacement. And I think when we talk about knees, we really talk about things being within 1-2 degrees of where we want to put them, within 1 to 2 degrees of where we actually think we put them. If we talk about hip replacement, we want the acetabular component to be close to where we think we're putting it. We don't want an X-ray where we have a surprise in terms of our acetabular component position. And we want leg length to be as close to perfect as possible. Patients complain about leg length. We don't like X-rays that look bad in terms of acetabular component position. And we could argue back and forth about how important acetabular component position is in terms of wear or stability. But I think we all understand, or we're starting to understand, that functional position of the acetabular component may be more important than anatomic position. So I've been a guy who's used navigation for hip replacements for 15 years now. And when I started navigating hip replacement, it was all about anterior pelvic plane. So we registered the ASIS on one side, the ASIS on the other side, the pubic symphysis, and then we navigated our acetabular component to that anterior pelvic plane, and we didn't really pay attention to what happened after that. So what position the pelvis was in, whether there was rotation of the pelvis, whether there was tilt of the pelvis, whether there was anterior or posterior tilt of the pelvis. And we've really recognized over the years that the patients that are at risk of dislocation are really the patients who have stiff spines where their pelvis doesn't move when they go from a standing to sitting position, or the people that we get fooled by. So if we go by anatomic position, but their pelvis is in a weird anatomic position, we're not necessarily in the functional position that we're trying to get to. So that being said, I just have one case that I want to show here. That the patient had a hip replacement done on one side several years ago by one of my colleagues. And we'll talk a little bit about that hip replacement. And then I did the other hip replacement recently. So all patients that I operate on today for hip replacements I get EOS films where I see their spine, their pelvis, and their lower extremities. And you can see this person's had a number of orthopedic procedures. But we get these images both sitting and standing so that we can see what happens to the pelvis when the patient goes from the standing to sitting position. We can see whether the position of the pelvis changes. So I recognize that on this image, because it's showing the whole lower extremity, you can't see a close-up of the hip. But the things that you can see very quickly on this is, number one, you can see that this patient has a pretty significant scoliosis. Number two, you can see that this acetabular component, even from here, looks pretty flat. And number three, when you look at the lateral x-ray, and I recognize that people don't often look at these lateral x-rays, so they're a little funny to look at, but it really looks very flat. So you can imagine if this person went to a sitting position, how easy it would be to impinge in the front here and dislocate out the back. So if we move on with this specific case, we then go to the sitting position, and I get these sitting images in everybody. And again, you can see the scoliosis that the patient has. You can see that this pelvis, even in sitting position, does not correct. You've got pelvic obliquity in the sitting position. And again, you can see just with this patient sitting, the femoral component is almost impinging, or may in fact be impinging, in the front of the acetabulum. And you can imagine if this person flexed their hip a little bit further, they'd be impinging in the front and they'd dislocate out the back. Okay? Now, I will tell you, this hip was done by one of our senior colleagues who taught both Mike and I how to do hip replacement. He is a fantastic hip replacement surgeon. You get fooled by these complex spines and how that patient is actually positioned. So if we look at this one, you can see the scoliosis was measured at 34 degrees. Okay, so a pretty significant scoliosis of the spine. And then I just do my standard preoperative templating like I would do in any case. But now, because the patient is sitting in that, or is positioned lateral in a functional position, so they're laying just on their side, but their spine is doing the same thing as it's doing here. Their pelvis is tilted the same way as it is on this image. And we're navigating, but we're not navigating to the anatomy of the pelvis. We're navigating to the functional position that this patient happens to be in. So we don't get fooled. If we were navigating to the anatomic position, we wouldn't put this patient's acetabular component in the position that we ideally would like to. And many other navigation systems that I've used, use the anatomic position of the pelvis and not the functional position of the pelvis. Okay, so if you're using the functional position of the pelvis, you're navigating directly to that, and it's almost like it doesn't matter where the pelvis is. It doesn't matter that you've got obliquity. It doesn't matter that you've got rotation. It doesn't matter what the spine has done, because you're putting this acetabular component in the position that's necessary to be a good functional position for this patient. So when we measure functionally on a postoperative x-ray here, you can see that the other side was 30 degrees of inclination and really no anteversion. This was a very flat cup in terms of version. And then you can see the acetabular component position of the implant navigated with OrthAlign, and we're at 45 degrees here, and we've got an appropriate amount of functional anteversion. And then you can see what you probably couldn't see on the previous image because it was zoomed out. There was a 6 millimeter leg length discrepancy on the pre-op film, and we've corrected that 6 millimeter preoperative leg length discrepancy. So acetabular component position, close to where we want to put it. Honestly, I don't really care if I measure that and it's 43 degrees or 45 degrees or 46 degrees. I want an x-ray that I'm going to look at that I'm going to say, yep, that's about right for the acetabular component, and not be surprised looking at my x-ray. And then I don't want patients complaining about leg length, so I want a very accurate leg length measurement. So that's just an example of taking a patient with a complex spine and almost ignoring the fact that they've got this spine deformity and pelvic deformity, and just putting the implant in where they need to be for the appropriate functional position of the patient. So with that, I will hand back to Mike here, and I think we're going to move on to discussion and questions.
Thanks so much, guys. That was really great. I think that's a really nice sort of set of cases to kind of show everybody the different utilities that exist with this kind of system. I just have a couple of questions, and again, hopefully these won't be too tough for you guys. But Don, let me ask you, one of the things that we always get when we talk about technology is questions on the learning curve. Is this going to take me forever to learn? Am I going to be in the OR for 6 hours? Is there something? So what do you think? How long do you think the learning curve for this technology really is? And do you think it's about actual results or simply about time?
So as far as what I would tell you, my learning curve was I do both anterior hips and posterior hips, and what I started doing was using this with some of my anterior hip cases, and I would tell you that I felt like it was actually increasing my efficiency probably within the first 5 to 8 cases. I do fewer posterior hips. I sort of keep that for people that have a lot of hardware that I'm going to need to address, or maybe I need to shorten the femur, or got to get to the back of the pelvis or something like that. And I would tell you that even in that setting, it was I do many fewer of those cases than I do anterior hips. But again, it was maybe within the first 3, 4, 5 operations, I felt like it slowed me down none whatsoever, if even probably helped me speed things up a little bit. And really, I guess to address your second question, I think that for me, it's about reproducibility and the confidence that you're just ready to go to the next step. My workflow is generally to put the socket in and then move on to the femoral side, and so when I know it's right where it needs to be, then I'm on to the next steps of the operation, and then on to the next case. So that to me has been a real just value added as far as time and efficiency, and it hasn't taken me many cases to feel really very confident with what I'm getting each and every time.
Hey, Don, can I ask you just a quick question? You talked about anterior hips that you started with. Has it decreased the amount of fluoroscopy time, or do you use fluoro when you do your anterior hips?
Yeah, that's a great point. So when I first started doing anterior hips, I would call in the fluoro, and I would try to check with my reamer and try to check the socket, and I had this just this very laborious workflow to check every step. And what was really the worst thing with that is that I feel like I'm fairly proficient. It doesn't take me long to do the operation, but I would be waiting for my x-ray person to come back, and they're out to lunch or they're at a coffee break, and I'm standing there waiting. And so that is actually how this really became really of interest to me. And the first few times I did it, I no longer take x-rays when I do the cases. And so now the only reason that I do an x-ray is our hospital has a policy where I have to have an x-ray before I'm allowed to leave the room, just to quadruple check our count, which, again, don't get me started on the utility of that, but I bring the fluoro in to snap one shot when we finish, and that's what we do now. So now I have essentially no x-ray in my anterior hip cases.
So Dave, some people don't like putting pins in the pelvis, or aren't comfortable putting pins in the pelvis, or sort of try to figure out the difference between that for navigation versus that we all learned for putting like an X-fix on the pelvis. Any pearls? What's your technique for putting your pins?
So great question, and I've been navigating hips for a long time, so I've been comfortable putting pins in. We have fellows, we have 6, 7 fellows a year that I end up, with you now, Mike, end up teaching people how to put these pins in. And we're actually a place where we've got guys that do Mako, we've got guys that do all sorts of stuff. So putting pins in the pelvis has become less of an issue over the years. But what I really found is, obviously you want to stay back from the ASIS, because you don't want to be in the region of the lateral femoral cutaneous nerve. So you want to be at least kind of 5, 6 centimeters back from the ASIS. And then you get to that thick portion of the superior pelvis, And what I do is I put my hand on it, and I put one finger kind of superior and one finger inferior and push down on the skin, and you can actually feel that ridge of the pelvis right there. And I just put the pin in on a pin driver vertical, okay, so I'm not coming down the pelvis, but I'm going vertical, and I start spinning slowly, and the pin gets a bite, and then you just go in probably about 2 centimeters with each of the pins, and you feel a pretty solid bite, and it's right in that big, thick area of the superior aspect of the crest. And you know that those pins have been pretty solid and pretty easy to put in.
Yeah, I would agree. I would echo those same points.
Any,
I'm sorry to interrupt you. I just described that as sort of the flare of the brim there, where just like you're describing, where that bone gives you a larger surface area. And I would echo the same point that I've not felt as though I need to drive these pins in there any sort of extreme distance. So they're very solid. I just run them down until I feel the other cortex. Maybe 1 or 2 threads into that, and that has been more than adequate, and I've not had any issues with that being an issue. And even in the osteoporotic patient, it's not been a problem.
And then, Mike, I think the other point there is putting the device on those pins. It's just like any other external fixator. The closer you put it to where the pins are fixed to the bone, the more rigid it is. So you don't want to have long pins and then fix it right at the top of the long pins. I don't care what length your pins are, you want to put the clamp on as close to the pelvis as you can. It's much more rigid if you get close to the pelvis.
So in keeping with sort of the technique side of this, how about the femur tack? Any particular thoughts or techniques in terms of putting that femur tack in to make sure you get it where it's going to be used?
So I basically, just before I put that pin in the femur, so you've done your registration of the pelvis first, then I do my exposure, and just before I'm ready to dislocate the hip, that's when I put the pin in and measure initial leg length and offset. So what I do is I put an O-Frank retractor over the front of the femur, so I've got the person on the other side of the table pulling on that retractor, so I've got a pretty good view of the lateral aspect of the femur. I then take my probe, and I actually put my probe down to touch the trochanter, and I look at a point where the probe easily goes down onto the trochanter. So you're not tipping forward, you're not tipping backward, you've got a pretty vertical, direct approach with the probe. Then I take my pin, my tack, and I put my tack in that spot. So that it's very easy to put the probe back in, and the probe sits in the tip of that of the tack without me having to hold it and without soft tissues pushing on it. And I think that's key. You want to just be able to lay that probe down into the tack, and then when it's sitting there and you've got your leg in the right position, you just push the button to get the leg length and offset.
I would absolutely agree.
I think the error is usually putting the tack too posteriorly, kind of because you're looking at it from the back, and you kind of put the tack over the posterior flare of the femur, and then it's really hard to get with the probe. So I think it's really helpful to kind of do it that way. And obviously, I learned that trick from you, so that's why I think it's good. So, hey Don, just kind of curious, since it can't be all rainbows and sunshines. Have you found any particular cases to be more challenging, or anything that you've sort of come across like, man, this seems to challenge?
I will tell you that the one thing that I've come across a little bit with the system is sometimes I get a little, I get the occasional error message, and I don't know if that's clearly that's not a case related kind of thing, but that has been easily resolved with just taking the battery out and putting the battery back in. That's been my only negative that has come around with the use of many of these in many cases. As far as any kind of really challenging case, I still wrestle with trying to use the straight impactor that is available with the system in really large patients. I still tend to have a problem with that, or just the really stiff hip and trying to get this even straight impactor into the position where you're where that you need it to be and with your real-time feedback, you know that it's not. And so, at times that can be a struggle. But, as far as any kind of case that this hasn't been helpful or that I found this to be, a hindrance or anything like that, I can't really think of something right offhand. Probably just some of the same things that, I would like to think that everybody wrestles with some of these same things. Really big patients or really stiff hips or, really severe deformity.
Yeah, so Mike, I would say the case that I not struggle with the most, but the one that I found most challenging are the patients where I want a significant increase in the length of the leg. So if I've got a patient who's really short, somebody who had dysplasia, somebody who had Perthes, somebody who's got AVN, who's had femoral head collapse and is really short, the problem is they're tight after you reduce them, and then when the leg sits back down, it tends to pull the whole pelvis down because all of those lateral structures, the IT band and all those lateral structures are tight. So it pulls the whole pelvis down, and when it pulls the pelvis down, the laser points down, and it's hard to get the leg adducted far enough to get it in the right position so that you can actually measure leg length. So the one little pearl there that I'll tell people, if you're trying to lengthen the leg more than 3, 4, maybe 5 millimeters, is when you take your first leg length measurement, if you've got the knee kind of propped up on a couple of sheets or something that abducts the leg a little bit, so that when you're coming back at the end after it's reduced, you can actually get the leg adducted far enough that you can get the laser in position to get a good measurement. Because the ones that you really lengthen a lot, those lateral structures get tight and it just pulls on the pelvis and it's just harder to get the leg lined up. That's probably my biggest challenge.
And I think that technique, Pearl, is actually useful for all cases. So I always prop up the leg on that initial registration, just in case, even just by the force of dislocating, sometimes you get that assistant who's a little aggressive, and just by the force of dislocating, you can actually tilt that pelvis and make that adduction angle difficult to achieve. So if you've always got the leg abducted
it's actually just
on
really interesting to just watch those pins as you go through the case. And normally, if you're doing a hip and you've got nothing attached to the pelvis, you don't really recognize how much the pelvis moves through the case. But if you're watching those pins and you know that you put those pins in vertical and you're 20 minutes into the case and they're angled forward or they're angled back or angled down, you put a retractor in, you can really see how much the pelvis moves when you're doing a hip replacement with the patient in the lateral position. And then you can really start understanding why we do get those outliers when you don't have some sort of device that's giving you numbers in relationship to the pelvis, because the pelvis really does move around a lot while we're doing a hip.
Especially in the heavy patient.
So one final wrap-up question, because I don't want this to go on for too long, sort of as just a final thought, any particular case that you've really found this to be very, very helpful, where it's sort of, you look back and you're like, man, that really saved me, or that really kind of gave me?
Well, some of those cases that I just presented, I would tell you that each one of those really I felt as though I had information that I might not otherwise have had. The leg length information that you get from these people with these, severe, almost, congenital deformities, where, they grew up their whole life with their leg that way and very short and, just problematic soft tissues. I think that the information that you get in that setting, you can't get that any other way. It's it's just not easy to template something like that and then reproduce that accurately and then be within a couple of millimeters. It's not uncommon for us to do some of these cases and be within millimeters. And when I think about how accurate that is, I mean that's really that's remarkable really to me because we've done some major deformities that are just severe problems, and they're just it's hard just to shoot from the hip and make something out of nothing there. And so this gives you really real-time information that has been very helpful. So I think any one of those that I just ran through, I think each one of those I had information that I might otherwise not have had.
Yeah. So I think the key to it is when the patient's anatomy is not normal. Right? When the patient has normal anatomy and they've got a normal arthritic hip, you can follow their anatomy and you can be pretty close on pretty much every hip replacement. But somebody who's got a bad spine deformity, so their pelvis just isn't sitting properly, you can't really follow their pelvic anatomy. Somebody who's had an acetabular fracture, so their acetabular anatomy is strange. And the third one that we didn't really talk about today in terms of leg length is traditionally, in the way I was taught, and like I think the way you were taught, is we've always been taught to measure this LTC number, the lesser trochanter, the center of the femoral head, and that's how we've always measured leg length. But really all that does is measure femur length. It doesn't measure leg length. So if you raise the hip center because that's where the bone is and you're trying to put the acetabular component in that position and you just reproduce their LTC, your leg's going to be long. So because this gives you overall leg length measured from the pelvis and not just femoral length, I think it helps you when you've got abnormal acetabular anatomy.
All right, well, I just really want to thank our faculty tonight. Don, thank you very much. Dave, thank you very much. I appreciate you guys' time tonight. Thank you to everyone who took the time or takes the time to watch this video. And certainly, if you have any other questions or any interest in learning more about this technology, please reach out to your local OrthAlign reps, or certainly feel free to reach out to any of us at any time. Again, thank you all, and have a great day, evening, night, or any other time that you might be watching this.